Here is our game plan for today. We'll hit classification, jump into management, drop a key clinical pearl, look at a classic exam trap so you don't get caught out, and finish up with a quick recall question to test your memory.
All right, part 1, classification.
Okay, so starting with Crohn's disease, we break the whole thing down using age and location. Age is super straightforward. A1 is your pediatric group, 16 and under. A2 is that classic young adult presentation, 17 to 40. And A3, that's late onset, strictly over 40. Now for location, just think anatomically, from top to bottom. L4 is isolated upper GI. L1 hits the terminal ileum. L3 is the ileocolon. And L2 is isolated strictly to the colon. I want you to mentally take a picture of this right now. Every single Crohn's patient you see has to be boxed into these exact parameters.
Next up, we look at the behavior category. Honestly, this is where the disease pathology really dictates your surgical timeline. B1 is simply inflammatory, so it's non-stricturing and non-penetrating. B2 means stricturing, right? The bowel is physically narrowing. B3 is penetrating, where the disease is literally burrowing right through the bowel wall. But listen, you absolutely have to pay attention to that lowercase p. That's the perianal disease modifier. It's a massive deal. The second you see that P, it completely flips your surgical approach from a standard abdominal resection to managing some really complex fistulas and potentially severe sepsis.
So, your mental anchor here. It's ALB, age, location, behavior. ALB. Seriously, say it out loud a few times right now. If you can cement ALB into your brain, you are never going to forget the Crohn's variables.
All right, let's pivot over to ulcerative colitis. Now, notice how UC completely throws the ALB criteria out the window. Instead, it strictly relies on extent and severity. Extent, or E, maps the disease from the bottom up. E1 is ulcerative proctitis, trapped right there in the rectum. E2 is left-sided colitis, so it spreads but stays distal to the splenic flexure. And E3 is extensive colitis, blowing right past that flexure. Then you have severity, or S, which is basically your clinical thermometer. It scales really cleanly, from S0, which is clinical remission, up to S1 for mild, S2 for moderate, and boom, right up to S3 for a severe, life-threatening flare.
Moving right along to Section 2, Stage-Directed Management.
So, how do we actually manage Crohn's out on the wards based on this behavior stuff? Well, for B1, that's the non-stricturing, non-penetrating group, medical therapy does all the heavy lifting. Surgery is basically kept in your back pocket as a last resort for refractory cases or weird complications. But for B2, the stricturing disease, we have to pivot from medicine to mechanics. You've got to assess for obstruction. If it's just a short, favorable stricture, an endoscopic balloon dilatation can totally save the day. But if it's heavily fibrotic or totally blocked, you've got to step in with surgical mechanics. Think strictureplasty or a full-blown resection. Then we hit B3, penetrating disease and that tricky P modifier we talked about. This is where things get super aggressive. B3 means fistulas, abscesses, perforations, the whole shebang. You have to immediately drain those abscesses and get sepsis under control with IV antibiotics. Surgery is highly likely here for anything complex or uncontrolled. And for the P modifier, an exam under anesthesia, an EUA, is your absolute top priority to map out the disease safely. You'll probably be dropping in setons to maintain drainage, while your medical colleagues push hard with intensive biologic therapy.
For ulcerative colitis, the management follows a really logical, stepwise escalation. For E1 proctitis, simple topical therapy, like suppositories or enemas, is often enough. Escalate to E2 left-sided disease and you're combining topical with oral meds. By the time you hit E3 extensive colitis, you are pulling out the big guns with systemic biologics. And if they crash into a severe acute state or just won't respond to meds, you are immediately looking at hospitalization, aggressive rescue therapy, or ultimately a life-saving colectomy.
Section 3. A key clinical pearl.
Check this out. This is the natural history of Crohn's disease. It almost never stays static. It typically marches sequentially right down the line, from B1 to B2 to B3. It starts inflammatory, scars down to become stricturing, and eventually burrows deep to become penetrating. Understanding this trajectory is honestly absolutely crucial for your clinical foresight. When you're looking at your patient's classification today, you aren't just treating the now, you're actively anticipating the exact surgical complications they're going to face tomorrow.
And just a rapid-fire reminder to lock in those UC landmarks. E1 is the rectum. E2 is left-sided.
E3 is extensive. Keep those 3 anatomic borders crystal clear in your mind.
Section 4. The classic exam trap.
Look, whatever you do, never ever mix these two up under pressure. Crohn's uses age, location, and behavior. Ulcerative colitis uses extent and severity. I guarantee you, examiners love to hide an extent criterion in a Crohn's question, or they'll try to slip an age criterion into a UC management plan, just to see if you're awake. Keep your mental silos strictly separated. Do not fall for it.
Oh, and here is another classic trap, the L4 add-on rule. Remember how we said a patient can have Crohn's in multiple locations? Well, L4, the isolated upper GI disease, can actually be added to L1, L2, or L3. The location scoring isn't always mutually exclusive like we might want it to be. So if a patient has terminal ileum and upper GI involvement, they are officially tagged as L1 and L4. Make sense?
Okay, final section. Let's do a quick recall.
Here's your scenario. You've got a 25-year-old patient with Crohn's disease involving the terminal ileum and the colon. They've got a fibrotic stricture and perianal disease. What is their exact Montreal classification? I'm going to give you a couple of seconds to calculate the letters and numbers in your head. Ready?
Okay, time's up. The answer is A2, L3, B2, lowercase p. Let's quickly deconstruct why. A2, because they're 25 years old, slotting perfectly into that 17 to 40 bracket. L3, because the location hits both the terminal ileum and the colon, making it ileocolon. B2, because of that fibrotic stricture. And finally, the P modifier, because they clearly have perianal disease. If you nail that, congratulations, you've officially mastered this concept.
See, the Montreal classification isn't just about neatly categorizing data for a textbook. It practically dictates your treatment intensity and predicts surgical outcomes in the real world. So the big question I want to leave you with today is this. Will you recognize the pattern before those life-threatening complications arise? Mastering this tool saves lives, not just exam points. Thanks so much for running through this explainer with me, and I'll catch you in the next one.